Society and the Nova IVF group with Dr. Shagis as the head of the team in IVF Center in Manipal for having invited me for this presentation on international guidelines of PCOS. I bring greetings from our new department, 2-year-old department of reproductive medicine and surgery from Medical College, Manipal. As you know, we have started super specialty courses of MCH in reproductive medicine surgery from this year onwards, and we have our senior residents joined. We have 3 seats which have been filled up this year. Written from Manipal University. I always say PCO is an international guidelines is there, but it's a confusion of syndrome. It's a confusing syndrome. And everything is 3 in that. Everything has 3 problems and 3 treatments, and that is all you should know on PCOS. So I call it as confusing syndrome of 3. Now when you say 3 groups are confused as enough, number 1 is Rotterdam criteria, which we follow. Number 2, of course, is National Institute of Health, NIH, and Androgen Excess Society. I'm not going to tell you everything what they said, but the 3 societies have up to the same point, but hyperandrogenism is the same common feature in all the 3. And of course, irregular menstruation. They never said ultrasound has to show PCO. So if you understand, Rotterdam clearly said 2 out of the 3 means androgen excess, irregular cycles, and ultrasound showing PCO is 2 out of 3. But in an adolescent group, you must have all the 3. You cannot brand a young little fat girl as PCOS unless she has all the 3 in the Rotterdam criteria. That's the reason. All the other societies just opt on hyperandrogenism. So they also the same thing, oligoanovulation, biochemical or hyperandrogenism, and exclusion of related disorders. And this is the common ones: chronic anovulation, clinical or biochemical evidence of hyperandrogenism, and PCO by ultrasound. Any 2 of the 3 is important for Rotterdam criteria. Androgen excess society is the same story. Now let's understand the pathophysiology. Again, there are 3 things. One is insulin resistance, other one is androgen excess, and the last one is ovarian folliculogenesis, means they don't ovulate, so they don't get regular menstruation. Again, there are only 3 problems. Ultimately, all these things leads to polycystic ovarian syndrome, where there is hyperinsulinemia, irregular menstruation, and hyperandrogenism. There are only 3 things in the history. You can elaborate the history or summarize in 3 points everywhere. Oligomenorrhea, increased BMI is not always seen, but mostly it is there. And of course, excess hair growth. Again, the same 3 problems. There are 3 ultrasound findings which international guidelines have not said, but my observation is initially we said 10 to 12 antral follicles, but now because the machines are so very high sounding, elaborate ending kind of a machine, they said 20. So 20 follicles is considered as PCOS and not 10. And ovarian volume is still considered. Suppose you have still the old machine, so like we also have the old machine still, and that is, if you look at the volume, it should be more than 10 ml. The third point is increased stroma. International guidelines have not clearly said that, but when I do IVF, I know that the stroma is very thick, and when it pierces through that oocyte pickup stroma, the needle gets bent. Why should I know that point? Because a thick stroma means hyperandrogenicity. Thick stroma means excess androgen. They are all correlated with 3 ultrasound findings. Again, the pathophysiology is the same: hyperandrogenism, insulin resistance, and LH secretion. Now, LH is not estimated in all patients. Now, the international guidelines have not said you must be LH estimation. But I think if you find a PCO woman, you should do GTT. 75 gram glucose, and then 2 hours later you take the blood, and more than 140 milligrams is considered as insulin resistant. We have stopped doing insulin levels, fasting level, and that and this and so on. There's nothing else except GTT. Hence, insulin resistance is made out only by that. There are only 3 treatments, that is reduction of weight, lifestyle modification, induction of ovulation. I'm going to touch a very little of it. And of course, laparoscopic ovarian drilling, whether necessary or not, is the. So that's the talk. but international guidelines have complicated the same simple three things of PCO, and they said in 2018 certain subtle points. Now what they said was they endorsed Rotterdam criteria. They are not saying forget Rotterdam criteria, they are endorsing the criteria, but the red line you can, in the screen is very small to see, but remember that ultrasound is not necessary in most of the patients. Ultrasound is not even recommended, especially in adolescent group you don't have to do at all. That is very clear. The ultrasound will show PCO in a normal girl also, so they are not recommending. But within 8 years of menarche, both hyperandrogenism and ovulatory dysfunction are required, and ultrasound is not recommended. That means even up to 8 years it may go on. But we know that at least certain girls we suspect it may be PCOS. So whom are we suspecting? Of course, it's not clear, so small screen. EBR means evidence-based recommendation. CCR means clinical consensus recommendation. And the last one, CPP, means clinical practice points. I just want to emphasize again, evidence-based recommendation means strongest. So much of studies going on, evidence-based. Clinical consensus means people who have clinical sense meet together and say that is the clinical sense. And CPP, clinical practice point, which we all want to do in clinical practice. Now they are hopping on very important menstrual history. Anybody with irregular cycle from adolescent, you must suspect PCOS. Because the regular cycle is different. And look at that. Normally in the first year, that means 1 year you don't bother. After 1 year, if the irregular cycle persists, she may be getting into PCOS or she's already in PCOS. So they are saying more than 1 year and less than 3 years of menarche, anything less than 21 days and 45 days. So we thought 21 days is alright, they can bleed once in 18 days, 21 days. But that girl may be getting into a problem of PCOS. Anything more than 41 days is not 3 months. But after 3 years, it is 21 and 35. They brought down from 45 to 35 days. I think it's too much of dissecting the menstrual cycle. But look at the last one. Anybody with more than 3 months of not getting menstruation is PCOS. That is what menstrual history is a very clear evidence that when irregular menstrual cycles are present, the diagnosis of PCOS should be considered and assessed according to the guidelines. That means you have put that girl into another category of she may get into problems in later life. So for adolescents or patients of PCOS but do not meet the criteria, increased risk could be considered and reassessment advised at or before full reproductive maturity, means 8 years. You can wait up to 8 years, afterwards you cannot wait. And this includes those with PCOS features before combined OC pills, and those with persistent features and those with significant weight gain in adolescent. So just somebody putting on weight doesn't mean she's PCOS. She may be hyperthyroid also. But remember, extra weight in adolescent and irregular cycle, one needs to be very, very careful. Now biochemical analysis, we thought everybody should get that testosterone and androgen, all kinds of things, but it's not necessary. Assessment of biochemical hyperandrogenism is hampered by a lack of clarity. Depends on which lab, which machine you are using, and that's what I think. Direct testosterone assays are widely used, however, deficiencies and accuracy of these limitations, it's a limitation. That means you can't just left and right send a blood for testosterone in any lab. Why? Because the lab should be doing something like this. You know, the methods of direct assessing total circulating testosterone are direct radioimmunoassay and chemiluminescence are of insufficient precision. You have to ask a lab. In fact, I asked what they do another technique. If somebody does the old technique of radioimmunoassay and chemiluminescence immunoassay, it is not valid. That means that testosterone level is of no value. Inefficient, insufficient. So what they should really do is, so they have many other things. Now what we do is, the laboratories can provide calculated testosterone and all the indexes. Androstenedione DHA is again not necessary, have a more limited role and can increase the probability of detecting hyperandrogenism. What does it mean? It means we do not do all the time. Androstenedione dehydrogenase could be considered if total of free testosterone are not elevated. You can send it for testosterone, free or total. I don't even do that. because the next slide will tell me that is not necessary. But if testosterone is normal and such hirsutism and so on, then you send for DHA and the androstenedione levels. But interestingly, the testosterone section may be increased during mid-cycle. If somebody coming during ovulation, you should not do. You should do the follicular phase. And assessment of androgen status should preferably be done during early follicular phase in an ovulating cycling women, while diurnal variation means morning levels may be most predictive. So you cannot send testosterone and they come in the afternoon during ovulation. You ask them to come in the morning and then do the follicular phase time. I think that's what's important. Now, let's skip that. Now we should really have this kind of a machine. The biochemistry will tell us liquid chromatography, mass spectrometry, spark mass spectrometry, mass spectrometry, etc. That means that is a very complicated kind of a machine. Only then it matters. So international guidelines have said people are using left and right all kinds of laboratories and unnecessarily branding people as PCOS. But drug withdrawal, suppose they are mostly pills, drug withdrawal is recommended for 3 months or longer before measurement. So you wait for 3 months before you estimate. But once again, a great emphasis is clinical assessment is more important than blood levels. We do not do blood levels in my setup unless we have suspicion of something else. Assessment of biochemical hyperandrogenism is most useful in establishing PCOS, where clinical signs of hyperandrogenism, in particular hirsutism, are unclear or absent. Standardized visual scales are preferred when assessing the hirsutism. I think we should do. We have a protocol in our department. We should examine so many areas and do the Perryman Galway score. Long back they said 9. 9 means hirsutism, but now it is 4. 4 to 6. Even if 4 to 6 is present, it is PCOS. That means clinical, you can refer to Perryman Galway scoring, you can Google that. And it's easy to do that. So you don't have to do any blood test. Look at the scoring. 4 to 6 means it is definitely hirsutism and PCOS, and irregular cycle will tell us the same. What about anti-mullin hormone? It is not yet recommended for diagnosis, but in our clinical practice we know that normal anti-mullin hormone is 1.5 to 3.5 nanogram per ml. But anything above 5.5, I'm saying 1.5 to 3.5 is normal. Anything above 5.5 is evidence of PCOS, but not diagnosis. Again, AMH must be done in the proper laboratory, proper machine, and not with anybody's small kind of old machine. So AMH is not yet established for infertility AMH. So ultrasound needed or not, I have clarified that. It is not necessary in a young girl. Transabdominal ultrasound can still be used. More than 10 ml volume is considered PCOS. Transvaginal is obviously better. So on vaginal sonography, more than 20 follicles is considered as PCOS. Ovarian volume more than 10. And of course transabdominally if you do, in young adolescent girls we don't do anymore. So the radiologist should know this. Our clinicians must know this. You should not refer cases for ultrasound just to diagnose by ultrasound, because everybody who goes there will get PCO. So you should not even refer patients for ultrasound. Lipid profile is not done routinely. We know it's a lifestyle modification. All patients who have a long-standing PCOS must have lipid profile assessment. I won't do that. Glycemic status I've already told you. GTP is enough. 75 gram glucose and more than 2 hours is 140 milligram. There is no need to do any other test like before we do the insulin resistance test. But BMI more than 25 is very significant. History of impaired fasting glucose, impaired GTT, gestational diabetes in an older woman, family history of diabetes and hypertension are all risk factors of potential lifestyle changes, lifestyle problems in the subsequent part of the life. So we do oral GTT, sometimes it's just fasting glucose and HbA1c, and that's all. Now the other problems associated with PCO are plenty. We're not going to talk about it. We're going to talk about how they have depression, obviously, anxiety symptoms, obstructive sleep apnea, we refer them to ENT, psychosexual function referent to psychiatry, eating disorder, we don't know whom we have to refer to, dietary interventions refer to dietitian, and daily, the exercise is a simple thing. 1,000 steps, including activities daily, etc. And of course, we assess SMART. Should be SMART in assessing the smartness. Specific, measurable, achievable, relevant, and time-limited goals could include 10 minutes bouts, progressively increasing physical activity every 5%. That means we increase the activity every week. I'm not an expert in that because there are people in our hospital who would tell us the exercises and so on. So I think ultimately we know what to do next. Once diagnosed, assessment and management includes reproductive, metabolic and psychological features, education, self-empowerment, multidisciplinary care, lifestyle intervention, etc. and all that has been done. Little bit about pharmacological method. Combined oral contraceptive pills should be recommended in adolescent and adult women for hyperandrogenism and irregular cycle. Could be considered in adolescents who are at risk but not yet diagnosed with PCOS. For management of clinical hyperandrogenism and irregular, that's what we do. Those pills are given. Specific types of dose of progestins, estrogen or combinations cannot currently be recommended in these kind of patients. However, one thing interesting I found was, though I am giving cyclotron acetate in certain of these excess estrogen, international guidelines says it's not the first choice. The first choice is still simple OC pills, and cyclotron acetate should not be considered the first line, and because they have found certain incidents of venous thrombosis. I have not found like that here because when I find gross estrogen, I am still giving cyclotron acetate, though the international guidelines says start OC pills. I don't know what your experience is, Shubhalita, we have found, because from years together we have been giving cyclotron acetate and we have not had problem. However, maybe those people where they did these kind of guidelines, they all come from Europe and other places where the smoking incidence is very high, so I think like that. However, simple things of OC pills can be given, reduce BMI, etc. So, metformin has come back. We once thought we are unnecessarily giving all kinds of metformin, but in combination with COCP, metformin should be considered where COCP and lifestyle modification do not achieve the results. In women with PCOS for management of metabolic features, definitely if I find GT is abnormal, I will give metformin. If somebody is excess BMI, I will give metformin. But not all patients who have PCOS, we don't have to give metformin. But combination of COCP and metformin may be most beneficial in high metabolic risk group, including those with diabetic risk factors, impaired GTT and high risk ethnic groups. What about anti-androgens? In combination of COCP, anti-androgens should only be considered to treat hirsutism. After 6 months of COCP, that means you give OC pills first, wait for 6 months, if it doesn't go down, then you give anti-androgen. But I know how our patients do not want to wait for that long. We have to probably intervene a little earlier because the hair growth takes a long time. It doesn't get changed in 2-3 months. It may take 6 months. If you really look into the hair anabolism, metabolism, catabolism, or hair physiology, it's a completely different physiology by itself. But we know that metformin has gastrointestinal problem. The dose is 500 mg 3 times. You should give 3 times and not once a day and twice a day. But I would give once a day for 3 days, twice a day for another 3 days, and maybe increase it. Because you give 3 times from right from beginning, she's going to have nausea and vomiting. You can slowly increase the number of tablets per day. Anti-obesity pharmacological agents, of course, can be given, but it's not recommended by international guidelines. About this, I got interested. The anti-androgen pharmacological agents, when COCP are contraindicated or poorly tolerated, could be considered to treat hirsutism and androgen-related alopecia. Specific types of androgens, anti-androgens cannot currently be recommended, so we do not do that as a first line of management. Myo-inositol has been hyped by the medical companies, but the international guidelines are quiet on that. So, ionoacetol in any form they'll say, Cairo, Cairo, we can tell us this ratio, that ratio. Should currently be considered an experimental therapy of PCOS with emerging evidence on efficacy, highlighting the need for further research. Once again, not recommended by international guidelines, but you can try because sometimes you don't have anything else to do. So I am also giving, but not on a routine basis, but on a discussion on a platform. We are not giving IVF at all. Tubal patency test is not needed initially. You can directly give induction of ovulation and metformin. You are wasting time on tubal patency test. If they don't conceive, maybe after 6 months of trial, then you consider simple tubal patency test. However, it is not recommended. Letrozole is the first choice of PCOS and not clomiphene citrate. Letrozole should be considered the first line of treatment with anovulation and no other fertility problem. Clomiphene citrate can also be used. There is no contraindication for that. Metformin could be used alone in women with PCOS with anovulatory infertility and no other infertility factors improve ovulation, pregnancy and live birth. It's all, whatever you want to do, you can do. But I think a combination of letrozole and metformin works very well, and also if there is a BMI, excess BMI. Clomiphene citrate should be used in preference when considering clomiphene citrate or metformin for ovulation induction in women with obesity. That means obesity, I think you give metformin and give clomiphene citrate. But I still would give letrozole as the first choice because the response is really good. Clomiphene citrate could be considered with metformin rather than persisting clomiphene citrate alone in those who do not respond with follicular genesis. IVF is the last resort. I'm sure Shaviz will talk about the selection of patients for infertility. I didn't touch upon all that because it's a huge topic by itself. I did a general kind of a management. Of course, the last resort is IVF. But what you give, do you give pure FSH, recombinant HMG? It doesn't matter. We were all told only give recombinant and give pure FSH, but I've been using for PCOS even HMG, and we have had good results. So that's what international guidelines says. Urinary or recombinant FSH can be used in women with PCOS undergoing controlled stimulation, even for IVF, etc., with insufficient evidence to recommend specific FSH preparation. That means you don't have to bother. Exogenous recombinant LH treatment should not be routinely used in combination with FSH in women with PCOS undergoing controlled stimulation. I was talking about this LH at the beginning of my talk. Recommendation internationally doesn't say LH estimation, only AMH. But I do not know, our experience is different. If I find the very high AMH, something like 8, and if you do second day LH, it will be high. That means, though there is no recommendation, you can do in certain of these selected patients because we know LH is a bad guy, LH is a bad friend. That LH is a friend but not too good. We want a friend to be quiet. So LH, little bit of LH is good, but too much is too bad. That will suppress increase androgen and suppress oocyte and ovulation. So too much of AMH, too much of LH, you bring it down. You give OC pills for 1 month, 2 months, and then the LH will go down less than 10. Now I am very fond of the number 10. Dr. Padmarao used to teach us number 10. 10 hours of labor, 10 centimeter dilatation, 10 centimeter lower segment, anything in obstetrics and gynecology is 10. Guess what? Guess number is 10%. So that FSH must be less than 10, LH must be less than 10. And all these are values which are not given in international guidelines, but it's a clinical practice being concluded. So, gonadotropin, the second line of management, who have failed in the first line of ovulation induction, and of course we can choose. But remember, when you give gonadotropin, there can be ovarian hypertension syndrome, which one needs to know how to manage, how to avoid, and so on. And finally, just the last 1 or 2 slides. Letrozole recommended for sure. Gonadotropins and metformin, the second line of management. Because the cost is high in gonadotropins, we have to counsel for multiple pregnancy, and more important is ovarian hypertension syndrome, and we must do follicular imaging in them. We can give clomiphene citrate if the first line doesn't work well. Of course, preferred when the other first lines are not available or unaffordable. more effective with patients with high BMI. We can give clomiphene and metformin. And finally, laparoscopic ovarian drilling. I'm not going to talk much about it because it's a controversy. However, international guidelines says it can be chosen in certain patients when you don't find response, not in the first line of management. If you don't find response to the initial therapy of letrozole, including gonadotropin, you can do. But you should know that Dr. Rajesh Bhatta, one of the finest endoscopic surgeons, is here. He will agree with me. Those days we used to see like the golf ball. Everybody working a whole part of tissue, but we don't do that. The rule of 4, only 4 punches, 40 watts, 4 millimeters depth, and what else is 4? 4 seconds. 4 seconds. So rule of 4 is important to do PCO puncturing, and we do not do too much of it. The third line is IVF, because IVF is not easy as well. My experience is IVF is quite good, but it's not that we get very good healthy eggs. So when you find too many eggs, very few are actually mature and few become embryos. So IVF is an art by itself, and Dr. Shavis will take care of the last part of IVF part also. And where first and second line management has failed. So IVF practice point, when you do IVF, we are a little bit of, I don't think people should know what we follow in IVF, but a little bit of it. We use some antagonist protocol because there is less of ovarian hyperstem syndrome. We use any of those things. HCG, we avoid sometimes giving a trigger because HCG can flare up the ovaries. We give leuprolide, GnRH analog to prevent ovarian hyperstem syndrome, and we do selective single embryo transfer, metformin therapy, and reduce OHSS. The last part I didn't want to elaborate because most of you are not doing IVF, but you can basically, one should know that PCO IVF means they get into ovarian hyperstimulation syndrome. They just block the ovaries. That is why we don't do the old technique of long protocol. We are using short protocol of antagonist. Antagonizing LH is antagonist. That is a new therapy for several years now, and we do not have, in fact ours I should say is an OHSS free clinic, but we do find mild OHSS occasionally. But we don't get, because we have changed the scenario of, we don't give HCG in PCOS at the end of it. When you give HCG, they just block. We give GnRH analog and freeze all the embryos and transfer the subsequent cycle. Lab surgery, I've told you that. Bariatric surgery seems to be one of the fashion in certain cities, but it should be considered as an experimental therapy for the purpose of having a healthy baby, etc. But I've had patients coming to me with bariatric surgery, now they're pregnant, and I don't know how to manage after that. So I'm referring to the obstetrics and gynecology section because you can't do GTT, you can't get tube food, they get anemia, they get all kinds of problems because they're not eating well. That is not recommended as a first line. And finally, we should know 2 types of obesity. Everybody knows that, the pear-shaped and the apple-shaped. But I just want to end by saying, whatever international guidelines say, whatever experience, concentrate on the adiposity. Adiposity is body fat. It's important to understand. Look at that. We have visceral fat. The storage fat is subject to the viscera. I just wanted to look at that. The visceral fat is the one we should understand. Somebody who's slim also can have visceral fat. That visceral fat is the culprit. Now, when you find too much of fat in the inside the abdomen around the organs, they are insulin resistant. That is why our physiotherapists in our place will direct exercises towards the abdomen and internal part of it. If you remove the adipose tissues infiltrated by inflamed macrophages that release tumor necrosing alpha, interleukin 6 and so on, linked to inflammation and insulin resistance. Now the abdominal fat, what is it? The body fat is considered like an organ. So that fat has to be looked after because visceral fat is the worst for metabolic problems and needs to be reduced by proper directed exercises along with your metformin. I just want to conclude by saying adiposity, look at that. Lean adiposity, you find monocytes, macrophages. The middle one is expanding fat. Too much of fat, look at the obese. Inside cell is dead. A dead cell will cause inflammation, interleukins, tumor necrosis factor and so on. That is why we have to reduce the fat. So to conclude, Greetings from Manipal. Those who have not seen yet Manipal, please go around and see Manipal. If you just join, look at Deva Suvarna and so on. So thank you, Shabis and your team for inviting me, and Krishna and Maria and the other for inviting me. Thank you.